Okay, so good morning, everyone. For those of you who don't know me, my name is Shawnee Cody. I guess you would maybe say a training consultant or something like that. I have been working with Peter James Development for probably 6, 7 months. Worked on treatment plans, I've done trainings, and I am pretty familiar with the ICANotes computer system and creating treatment plans in the system. So I got asked to do this training for you guys. Keeping treatment plans up to date is one of the most important pieces of case management and things like that because it is one of those things where if it's not updated, you technically can't bill on it. So what I am going to do is share my screen. I'm going to kind of run through just a really brief PowerPoint presentation that I created about treatment plans. I want to say that Derek emailed it to everyone yesterday. And at the very end, it has instructions on how to create an initial treatment plan and then update a treatment plan that has already been created. But I'm going to walk you guys through those steps too. I personally do better when someone shows me how to do it as opposed to just having instructions. So let me pull up my little, there it is, my little screen. Okay, so let me get my slideshow started from current slide. So basically, treatment plans are also called an individualized service plan, ISP, whatever. And then in the treatment plan, you need to have goals for all of the problems that are identified in the assessment. So if a client has both mental health issues as well as issues maybe with finding employment or finding housing, something like that, you're going to want to include a goal for that as well. You can include like a housing goal or something within a mental health diagnosis goal, for example. But the nice thing about ICANotes is that they also have a whole like social section for goals. So there are goals for housing, there are goals for finding employment, things like that. Um, and your treatment plans need to have a goal for all of the different diagnosed mental health needs of the client, unless it's being deferred. So if a client is like, hey, if a client is diagnosed with depression and anxiety, for example, but they're saying like, hey, I only want to work on my anxiety right now, you would just kind of note that in the assessor would note that in the assessment, and then wouldn't need to write a goal for the anxiety the depression at that moment. So basically, as you will see when we are creating the treatment plans, you might end up with multiple goal problems or goals for a client. And then also, if you have questions, please just stop me as we go. I'll leave some time at the end for them as well. This particular part's pretty straightforward. I expect that people will have questions when we're going through how to do a treatment plan. So the treatment plan is so important. It's basically the blueprint of the services that the client is receiving, and that's what allows the workers to bill. So the treatment plan is laying out what services they're receiving, whether it's case management, TBS services, day treatment, whatever, who is doing those services, and then how frequently those services are supposed to occur. And then legally, you can't bill on an expired treatment plan. It has to be kept up to date. The state says that treatment plans need to be updated minimally every year. but I find that most agencies do updates every 6 months. Some do them every 3. It just kind of depends on, what your particular agency says. I know you guys do them every 6 months, but, you also want to do a treatment plan update if something major occurs in a client's life that might impact their mental health. For example, if a client suddenly loses a significant support due to coronavirus, like their, mom dies or something, and that was their major support system, you're probably going to want to update the treatment plan to address that. Okay, so with treatment plans and progress notes, your progress notes need to come from your treatment plan. So everything that you're doing with the client in terms of your interventions needs to be on the treatment plan. As in my current role with a different agency, all I pretty much do are chart audits. I'm the director of compliance and quality assurance at another agency. So when I'm reading through progress notes, I am making sure that if a note is saying that a client is being linked with a community resource, for example, there is some kind of intervention in their treatment plan for linking to community resources. So everything that you're doing with the client needs to be in the treatment plan. If it's not there, you can't do it. So keeping treatment plans in compliance. You want to address the client's primary diagnosis as the first problem, and then kind of work from there. So if a client's primary diagnosis is depression, that's going to be your first problem that you're going to work on. And then from there, you'd want to address, anxiety, housing, whatever. And then you want your goals, objectives, and interventions to match your diagnosis. I have read countless treatment plans where, a client might be diagnosed with depression, for example, and, one of the interventions is something, or goals or interventions is, client will not disturb or disrupt in the classroom. And I'm like, there's nothing in the assessment anywhere saying that, the client has disruptive behaviors in the classroom. So just making sure everything goes together. In the treatment planner in ICANotes, it is set up really nicely where everything is kind of related. So if you choose a particular short-term goal, it's going to come up with relevant interventions for it. So it's you have to actually kind of work to make things not go together, but I've definitely seen it done. Okay, come on, I hit the button. Okay, so when you are updating a treatment plan, you want to make sure that all of the dates are changed in your treatment plan. And you also have to make sure that all the dates are changed in each goal. So when you change one date in a treatment plan, it doesn't just change everything. What I have seen a lot is that someone will go in and update, again, let's say the client has a diagnosis of depression and anxiety. Someone else is going to go in and update just the depression goal, and they forget about the anxiety one. And one of the things that I've also kind of noticed recently is that, and again, I'll address this when I actually go into the system and show you guys how to do this, but if you are going in and updating anything to the treatment, anything in the treatment plan, you need to go ahead and push those dates out again. So when you are changing dates in the treatment plan, you want to have the target date set as 6 months from the date of review or creation if it's an initial treatment plan. And then your completion date is a year from the date of the review or the initiation of services. So if I were updating a treatment plan for today, my target date would be July 16th. And then my completion date would be January 16th of 2022. So one way to kind of keep things that you've got it right is that each date should kind of be 6 months apart. Okay, I clicked it again. There we go. You want to fill in every single box on the treatment plan. There should never be anything that's blank. The only time that you would probably leave something blank is if you didn't know who a worker was coming in. So like, let's say that you know that a client is going to be receiving TBS services, but you're not sure who that worker is going to be yet. You can leave like a clinician name blank, but you never want to leave any dates or anything or frequencies blank. And you want to make sure that you are listing yourself on the treatment plan as well as someone who's performing those interventions. Making sure that you're using the correct language for each service. Again, this will make much more sense when I actually show you the treatment plan. The not so nice thing about ICANotes is that all of the interventions that are already in the system kind of default to say therapist/counselor. But, I would say 95% of the time, it's the case manager that's actually going to be performing those interventions. So you have to remember to change therapist/counselor to, QMHS, QBHS, whatever. Making sure that all your sentences are complete. Again, there will be some sentences where you need to kind of finish off your goal. It might be, a client will reduce frequency of anxiety to no more than, and then, you need to kind of finish the sentence, finish that sentence. I've seen some people just leave it blank and then just kind of fill the frequencies in, but you need to make the whole goal like a complete sentence. And then making sure that you're not repeating interventions that you've used in other short-term goals. Obviously, there's going to be some repetition, but if you have the same interventions for each short-term goal, that's not okay. And you're also going to be really limited in the number of interventions that you can do with the client. So remember, like this plan is good for 6 months. If you only have one intervention, it's like, oh yeah, we're going to journal each time we see each other. If I was a client, I'd probably stop responding to phone calls after a while because I'm not going to want to journal, 2-3 times a week or every time, that I see my case manager. So just real quickly, the components of a treatment plan. Each identified problem should only have one long-term goal. You don't want to have many. You don't want to overwhelm the client. If there are several things that, the client wants to accomplish, then that's when you add them as short-term goals. I once saw a treatment plan where there were literally like 9 long-term goals for a client. And I'm like, this poor client, like, they're probably just like, I give up. Like, this is way too much for me to work on in 6 months. And then you also want to include those target and completion dates because we need to know when to go back and revisit and possibly revise these goals. Right, short-term goals. So you need at least one, preferably 2 or 3 short-term goals. Again, this is what the client is going to be working on regularly. And this is also going to be what they're working on with you in their sessions and then outside of your sessions as well. So, keep in mind that, the client is going to be hopefully practicing their skills outside of sessions. The fewer short-term goals you have, the fewer interventions, and therefore the less variety that you might end up with in your sessions. And then one thing that the agency is doing is adding a goal for each service line that's offered, whether or not the client is actively using it at this time. And that makes it a lot easier actually to go and update treatment plans because you're not adding a whole bunch of short-term goals and interventions. They're already there, they just need to be activated. My computer is so slow. Come on, I just clicked. Okay, so available service lines. So for your children, you've got obviously your case management, you have day treatment, therapy, TBS services, and med management. So again, even if some of those services aren't present right now at the agency, they might be in the future. So that's why they're on there. And then adults have the same services minus day treatment. You know, they're too old for day treatment, so they don't get offered that. Interventions. So you need 2 to 3 interventions per short-term goal. Like that's my recommendation. Sometimes there might only be one that fits in ICANotes, and that's fine. And this is what you as the clinician are going to do for the client so that they can work towards accomplishing their goal. And again, making sure those interventions make sense when you're adding them to the short-term goals. Again, I have seen treatment plans where the short-term goal is, you know, client will not disrupt in the classroom, and the intervention is, you know, client will have a psych eval. And it's like, okay, like I kind of get how you're getting there, but not entirely. And you're always going to want to include an intervention for linking your client to community resources. This is what is going to allow you to, you know, speak with their caseworker at Children and Family Services, or take them to a food bank, or, you know, something like that. Okay, so frequencies, making sure that your frequencies are correct and sensible. The frequencies are dictating how often and how long you're going to be seeing the client. You don't want to use forever. You know, you're not going to keep your client in services forever. And you don't want to say to tolerance, because, you know, a client may not tolerate an intervention and therefore it's pretty much useless. Auditors, Medicaid, OMAS, whatever, they are going to look at these frequencies and hold you to them. You know, if you're saying you're going to see a client 3 times a week, they're going to be looking to see if you saw that client 3 times that week. And again, will make more sense when we go into the treatment plan and look, but you don't want to, you know, choose like, you know, you'll see a client 3 times a week for 60 minutes, because that means you can only see that client for 60 minutes. If you bill for an hour and a half, you have to justify why you're adding that extra half an hour to a session. Okay. And then, so signatures. You need to have a signature for every treatment plan that you do. Should be done electronically. I will show you how to do that in the treatment planner. I did see a few treatment plans where it looked like there was a treatment plan update, but for some reason, it was just updated for a signature, and you don't need to do that. If the client is under 18, the parent or guardian also needs to sign that, like no exceptions.
I have a question on that.
Yes.
You are so the people that's doing the treatment, are we responsible for that, or does the case manager workers get those signatures?
So if you are just updating the treatment plan, the case manager would be the one that is responsible for getting the signature. So if someone is just kind of writing the treatment plan for the case manager, then yeah, the case manager is going to be the one to get the signature. Yep. Okay, so statuses. Again, will make much more sense when we go to the treatment planner. You always want to indicate that you know, you've met with the client to review the goals. It says face-to-face, but you know, basically it means that you've spoken with them, whether it's, you know, via telephone, telehealth, or literally face-to-face, especially in the pandemic, that the licensed professional who will be your supervisor agrees with the assessment as it's written, which means the diagnostic assessment. If the assessment's been accepted, then, you know, obviously someone has agreed with it, and that all of the services are medically necessary. So you're basically saying like, yeah, the client needs case management, they need TBS services, they need day treatment. All of these are medically necessary for this client's mental health for them to improve. If you are doing a review, you need to do the status update for each particular problem, as well as including a few personalized sentences about the client's progress. It doesn't need to be long. You know, you could literally say something like, client has identified some coping skills, but still struggles with being disruptive in the classroom. You know, services need to continue. Boom, done. And again, it needs to be done for each identified problem. It's not going to actually copy over to the other problems. Okay, so this is where I tend to see a lot of issues and where people get confused, is like the compiling part. So you want to make sure that the date is correct, which is going to be kind of in the upper left-hand corner. This is the date that you actually meant to complete the treatment plan update with the client. It might not be the day that you're doing the treatment plan, but that's the day that you actually physically discussed it with them. You want to make sure that you've chosen what kind of plan it is, whether it's an initial, a 6-month update, an interim update, whatever. You want to include all of the members of the treatment team, whether or not they attended the review, because there's a spot where you can check who attended the review, and then make sure that you have the diagnosis show up on the treatment plan. You don't need to include the medications. Sometimes clients have like a list of medications that's like 20 pages long, and it just makes a really long treatment plan. You know, I suggest maybe adding medications if one of your specific goals with the client is to make sure that they take their medication, but it's not necessary. And then just some additional information, again, will make more sense when we go in there. You're going to want to ask if you're going to be asked if you want the system to basically stamp it with today's date and calculate when the next update is due. If you choose that, if you choose yes in that pop-up box, you're automatically setting the plan to be reviewed in 3 months, not 6. ICANotes is set to have the plans be renewed every 3 months. That's pretty standard for a lot of places. Unfortunately, that can't be changed. You have to change it manually, and I'll show you guys how to do that. And then each time that you try to save a treatment plan to progress notes, you're creating a copy of the treatment plan. So, you know, keep in mind as you are updating and creating treatment plans, you might end up with like 15 of the same treatment plan if you're not careful. And so basically a non-compliant treatment plan is not acceptable. You have all of the tools that you need to keep your treatment plans in compliance. Talk to your supervisor. I can certainly give you guys my email address. You can always shoot me an email and ask, but you know, make sure that your treatment plans are up to date. All right, so I am actually gonna stop the presentation and actually show you guys what updating a treatment plan looks like. What I am going to do real quick though is pause this and go let my cat out of the bathroom because she is yelling at me. And it is I think I'd much rather tolerate the cats running around and chasing each other than my cat yelling at the top of her lungs at me. So give me 1 second, I'll be right back.
Hey guys.
Good morning, everybody.
Be a good girl.
Good morning,
Okay,
everybody.
Good morning.
Okay. All right. I'm back. This is the troublemaker. Hi. She is adorable, but wow. She's like a small child. So my goodness. All right. Let me share with you guys my screen. Okay. So what you should see now is basically the chart face for John test. I'm going to show you guys, like I said, how to kind of create an initial treatment plan, because once that is done, I think that you guys will have a better idea of what it takes to update a treatment plan. And I'll also kind of have some different little tricks and tips that will make things a little bit, hopefully a little bit easier. Yeah, I see a raised hand.
Hi, good morning.
Hi.
I was having difficulty getting in this morning, but I'm Shonda Williams.
Hi.
I wanted to know,
Mhm.
will we have access to this recording?
Yes.
Okay.
Yep.
Before
I am gonna.
Before I write my hand off, you know.
Yes. Yes, I am definitely recording this, and I'm most likely gonna have to upload it to like my YouTube channel or something, but I will make sure that the link gets emailed out to you guys so that you do have it. I want to make sure that you guys can go back and look at this and pause it and stop it and rewatch it as many times as you need. So absolutely, you will have access to that. So, okay. So on the client chart face, you will actually see that there's a treatment plan tab over here. Normally, there's like a little light gray text here. It says due. When you created a treatment plan, it's actually going to show you when the next due date is. So you kind of have like a little snapshot of it. You don't have to actually go in and take a look right away. So when you click on the treatment plan tab, you get taken to the treatment plan list for the client. Normally, you're probably only going to have one treatment plan in there. Sometimes a client might have a couple if one is recreated or one is like so messed up that someone went in and created another one. But usually you're working on the same treatment plan because you know, again, you're just kind of most of the time changing dates, maybe adding a couple interventions, but nothing is usually changed very drastically. So to start a new treatment plan, you're going to go to this button over here that says add a new treatment plan for this patient. And you're basically going to give the treatment plan a name. So I'm just going to call this one John Test Initial. And then my suggestion is as you update them, you know, you want to say like John Test update and then maybe the date or something like that. So you know, okay, this was updated then. The type is always going to be general. Chemical dependency is going to give you a completely different format, and so is classic. So again, always general. The last done date is the day that you're actually either creating or reviewing the treatment plan. So last done is obviously, we're doing it today, so it's going to be January 16th. And then next due is 6 months from the update. So July 16th of 2021. 16th, okay. And then you're always going to want to choose for site name, you're always going to choose Peter James Development and Independent Living, Inc. Ignore the telehealth, just choose the PJD, and then you're going to hit save. So you'll see right here, it ends up on the line, and then you're going to want to check the default box because that's actually what is going to make, sorry if you can hear a whole bunch of banging, that is literally my cats chasing each other. When you check the default box, that is actually what makes it show up here. So now you see we have a date here. Again, if there are it's more important if there are multiple treatment plans, but you're going to want to check default. And then the other thing that we'll actually see when we're done creating this treatment plan, I'll show you the chart face again. The default treatment plan, when you run a report, for example, of treatment plan due dates, it's always, the system's always going to pull from the one that you marked default. So if you have a treatment plan marked default that's 3 years old, it's really going to look like that treatment plan is overdue. So to begin to create or update whatever your treatment plan, you are going to hit open. And you are going to get taken to this screen where there are a whole bunch of tabs across the top and a blue box here that says add a new problem or need. So each time that you want to add a new problem for a client, so let's say that a client has been diagnosed with anxiety, for example, we're going to go to add a new problem or need. And then on this side, you're going to see all of the mental health diagnoses. And you'll see up here too that there are 4 buttons that they say like psych, nursing, social, and rehab. It's going to start out on the psych selection. 9 out of 10 times you're not going to need to choose any of these other libraries. I was saying earlier that in ICANotes there is a library for like more social type issues like housing, job searching, things like that. If you click on the social button, you're actually going to get those particular problems, if you will. So you see like economic problem, legal problem, things like that. Just keep in mind that you can't switch between libraries. So you can't have the social library here and then choose interventions from the psych library. You're kind of stuck with what falls under those categories. So we're going to go back to the psych tab and we're going to choose anxiety. So ICANotes is also always going to kind of populate left to right. So when you choose anxiety, it's basically saying, okay, client's anxiety has been identified a problem. It requires treatment, and here's how the client's problem manifests itself. So you're going to get a list of manifestations here. It's important to choose at least one because that is where your short-term goals are going to come from. If you don't choose any of these manifestations, you're not going to have any short-term goals to choose from. If your client is manifesting their symptoms in a way that is not listed here, my suggestion would be to choose the closest manifestation that is to how they exhibit their symptoms. So I'm going to go with just generalized anxiety disorder, and then you're going to choose some details. So the client, there's some excessive worrying, impairment in functions, shifting focus, give them some somatic complaints, avoidance of social activities. And let's say that the client also has a history of anxiety without history of treatment and was not prescribed medication. And again, once you choose your one problem, you can't go back. You can go back and add other problems, but it's really going to mess up your whole treatment plan. So just stick to one diagnosis like per active problem. So again, if this client was also diagnosed with depression, finish your anxiety goal and then go back and add a depression goal. So I'll show you that. So after you have chosen your manifestation and your details, you are going to go over to a long-term goal. And you are going to go and choose a general long-term goal for your client, something that is probably going to take several months to work towards, and that could be continued several times if need be. So I'm going to choose the one that says reduce anxiety for daily functioning. So it's basically going to say client will reduce overall level, frequency, intensity of anxiety so daily functioning is not impaired. And if let's say that you generally like what the long-term goal is saying, but you want to switch out a couple of words, you can go ahead and kind of like type in this. Like you can add what you want, you can subtract what you want. So that's nice too. And then you are going to go and choose your target dates and your completion dates. So again, our target date is going to be July 16th, and your completion date is January of 2022. There we go, January 16th of 2022. And the important thing to remember here is to hit set for them. If you just put the dates in but don't hit set, you're not going to end up with the dates there. I think it's the only one of these where you have to hit set. Everything else is like in a little box. So this is a long-term goal that your client is going to work towards. So after long-term goals comes your short-term goals. So as you can see here, this is what I was talking about when you needed to choose your manifestations. So it's saying pick a manifestation. If I start with generalized anxiety disorder, it's going to give me a whole bunch of short-term goals that are related to generalized anxiety disorder. So you want to choose some goals that are relevant to your client and that your client is capable of doing as well. So like, let's say, let's see here. I'm going to go with, let's give this client some psychoeducation for anxiety. Let's have them learn an emotive vocabulary. Let me just give them one more and let's give them learn some coping strategies. History of anxiety. I mean, for me, I don't generally add too much from that just because a lot of them are the same. You'll see that the short-term goals for the manifestations are pretty much the same. A couple of them might be a little bit different. Like I see, learn to communication strategies to decrease anxiety. So you may not end up with a short-term goal for each of the manifestations, especially if they don't apply or they're just going to be repetitive. And then the other thing that I'm going to call your attention to is this column over here on the right. These are where what are called custom buttons live. So as I was saying earlier in the slides, you're going to be adding the different service lines that are available to the client, whether or not they are currently receiving them. So there are different short-term goals here for each of the service lines. So John Test is 15, so he is going to get the following service lines. And I do actually have a kind of cheat sheet of these custom buttons. I will make sure that you guys get them. And basically the cheat sheet has the actual wording of each of the short-term goals, and then also how to fill them out in terms of like frequency and target date and things like that. And it's not so much an issue now, but you'll see on the intervention tab that it becomes an issue if you don't know what the intervention says. So let's see, I'm going to click on generalized anxiety disorder, and then I'm going to choose, hold on, service coordination. And then I'm going to say, it's basically asking like, do you want to add this short-term goal? Yes. All right, Shonda, I see you have a hand.
Yes, before we move forward, I am still playing back what you were saying about, I understand the problem, the need, putting that in. Is there a reason, well, I know there is, but what is the reason specifically for having generalized anxiety disorder in addition to history of anxiety?
So let me go, right. So let me go back to here. So sorry, my cat just knocked something off my fridge, and I'm like, oh, it's probably the paper towels. So when I chose manifested by generalized anxiety disorder, I'm going to do it again. It gives you different details. So you can choose how your client is manifesting their generalized anxiety disorder. When I click on history of anxiety, you'll see that the details also change. So you can have add different details. But then when I go back to the short-term goals, when I click on generalized anxiety disorder, I'm going to get this list of short-term goals. And then the history of anxiety is going to give me possibly a different list of short-term goals. I generally find that, especially in terms of short-term goals with the manifestations, are very similar. But I do know that with different diagnoses, there are some manifestations that do give distinctly different short-term goals. I generally see those in things like depression and like oppositional defiant disorder. I do know that, for example, if you choose certain manifestations with depression, let's say that the manifestation is suicidal behavior, you're going to get some short-term goals that say, client will create a safety plan or something like that. But it may not have create a safety plan in different manifestations under depression. So it's really
it's really about having the variety of the
goal
pick.
Yep.
Pick of the
Definitely.
goals.
Yep.
Okay.
Definitely.
Thank you.
You are welcome. Okay.
And you'll have to excuse me. My little one has just awakened.
Totally fine.
And I hear things, she's hungry, so I'll keep it on, but I am going to go fix her.
No problem. No problem. So with the manifestations, you're going to choose, just make sure you have one of the manifestations chosen to add your custom buttons. I generally choose the one that seems to be most relevant to that particular custom goal. So I added the short-term goal here of service coordination, which is basically saying that the client's going to attend all of their external physical and behavioral health appointments to reduce physical and mental health symptoms and increase their ability to function in their environment. The short-term goal for therapy, again, you want to click yes. Basically saying that the client is, gotta scroll down, going to participate in individual therapy lessons or sessions to address mental health symptoms that are causing impairment in function. For TBS goals, the client, it basically says, again, participate in TBS services, utilize a variety of evidence-based practices to address mental health symptoms. Again, this is a child, so day treatment, participate in, there it is, age-appropriate coping, social and emotional regulation skills that are evidence-based through day treatment programming. And then last but not least, the medication goal is basically scheduling and attending a psych eval. So these are the short-term goals that are basically for the service lines that are available or will be available at some point. And so if I scroll back up here to the very first short-term goal that we added, you're going to see that there are different boxes here, like frequency, target date, things like that. And then the short-term goal itself. So the thing too to remember about short-term goals, you need to make them measurable. So like this right here, John will attend relevant psychoeducation regarding anxiety and its victims. And I'm like, well, number one, I don't like that phrasing. So we're going to get rid of that. I'm like, anxiety and its victims. So we're going to completely get rid of that and say, John will attend relevant psychoeducation regarding anxiety at least, let's say, 3 times per month. And then when you go down here to frequency, you are going to choose 3 times per month, and then you're going to choose 6 months. So your progress is going to say working on. That means that it is currently something that is being worked on. And it's basically an active goal. And then your status is going to be effective. If it's ineffective, it basically means it didn't work for the client, and you're pretty much only going to use those when you're doing an update. And then you'll also see with the different types of progress, you've got working on, partially complete, plans to start soon, almost done, completed, decided not to complete. And again, yes.
How can we put in effective if it's a new treatment plan?
So you want to,
and you're working on it.
Right. So I get that question a lot. And, if it's ineffective, for me, if you're saying it's ineffective, my question would then be, well, if it's ineffective, why are you working on it?
Well, no, and I understand that you don't want ineffective, but what I'm saying is if this is a new treatment plan and this is a new client and you say that the progress is, this is what we're going to be working on, how can we make the determination just as we would not for ineffective? Because how can you say it's ineffective? Well, how can we say it's effective yet?
And I think,
are those the only, or is it a matter of those are the only 2 choices and this is the one that fits best?
That's pretty much it.
Okay.
There are only 2 choices.
Okay.
Yeah. But the other thing too is that I'm also going in under the assumption that this is going to be effective for the client. And again, when we're doing an update, if the client is like, I don't want to work on this anymore, it didn't work for me, that's when you're going to say, okay, that was ineffective. I know not to do that, and, use that goal again, kind of a thing. And then, so with the target dates too, they're going to be the same as your your long-term goals target dates. So you're again going to choose July 16th, and you can also kind of like double click and type in. I generally find that is a little bit quicker than going through and selecting, going through the months and things like that. Hold on, give me 1 second, guys. I can literally hear my cat eating my roll of paper towels, and that is going to be a horrendous mess for me. Thank you, Phoebe. Okay. Well, my cat had breakfast. Clearly, she ate my paper towels. Good job. Who knew such a small package could cause so much destruction? Clearly, I don't have kids, or I would probably know that.
Male cats?
No, she's a girl. She just really likes paper. So, Kia, did you have a question?
Yes, I wanted to find out where we're updating the progress and whether it's effective or ineffective, or is that something that the QMHS should do as well as they're going through? I know they put that information in there for the initial treatment plan, but as they're going through, should they be changing those areas as well?
So yes. So if you're doing a treatment plan update and you find that a client has maybe partially met a goal, or they were like, I don't want to do this anymore because it's dumb. I've totally had kids flat out saying, I ain't doing this. Then yeah, you can change the progress from working on to partially complete. You can change it to they completed the goal. You can change it to decided not to complete. So yeah, as you're updating it, you're definitely going to want to change the progress appropriately for sure.
Okay.
And oh, go ahead.
So only every 6 months we should really be doing that. Not necessarily, say if one of the things is that we had to do education on PTSD. If completed that education, should we, even if it's not 6 months out, should we go ahead and go in and complete that at that moment?
Not necessarily. My suggestion would be, unless there are several updates that you need to make or anything that's significant, just wait until that 6 month mark.
Okay.
Because if not, you are probably going to be making more work for yourself.
Okay.
And, you know, like, let's say that you go in after 2 months and you say, okay, you know, education about PTSD has been completed, but then, you know, you find yourself continually giving them some more education about it, you'd have to go right back in and kind of reactivate it. So
Gotcha. Okay.
my suggestion would be, yeah, unless there's a ton of updates to make, just leave it till that 6 months.
Got it.
So kind of like we saw up here, a lot of these sentences kind of need to be filled in. So what I have seen sometimes as well is it'll say, you know, client will learn and practice blah, 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 at least, and then no one fills in the at least, and they just kind of fill in the frequency. And it's like, okay, but at least what? Is it like at least 5 puppies? Is it 27 times a minute? Like, what is it? So you do need to make sure that you are finishing the sentence and making it make sense and making it measurable. The other thing that I am going to discourage is using percentages. If you're saying like, John will learn and practice emotive vocabulary, express feelings in appropriate ways at least 50% of the time, you're going to actually need to define what 50% of the time looks like. You know, is it 50% of the time at school? Is it 50% of the time at home? Is it both? And it's much easier to just say like, he's going to do that, you know, 4 times a week or something like that. So just remember, if you choose to use percentages, then you need to define what, you know, 50% of the time looks like, or 75% of the time. And for things to be statistically significant, you know, it needs to be at least 70% of the time. So really, you're going to be having to do 75 or 100% of the time, and often 100% of the time might be unrealistic for a client, especially once they're starting out. And then the other thing I want to discourage would be doing things like 5 minutes, 10 minutes, an hour, things like that. Because again, if you're saying the client is going to learn and practice the vocabulary, let's say 3 times per week for 30 minutes, you know, when you are meeting with the client, you only have 30 minutes in that time, for that session. But most of the time, my guess is you're billing more than 30 minutes. So if you do, you know, for that 6 months, you have that whole time frame, that whole time period when you are before that first treatment plan review. I hope that makes sense. I do know that there are several different types of mental health facilities that use ICANotes. So the minutes are really great for example, residential treatment, where, you know, you might go to a group for an hour a week or something like that, or an hour a day. but it's not necessarily the best to use minutes in a community type setting. So when you do, again, the initial treatment plan, you are going to go in and fill out, like I said, the frequency, progress status. And again, the status we're assuming at the initial is that it's effective. So you're just going to have status as effective for each short-term goal. And you'll have progress as working on for each short-term goal that you're actually working on. So like, let's say that a client is currently let's say that they're on the waiting list for therapy services. You're going to set your progress as plans to start soon. Same thing with maybe TBS services. You plan to start soon. Day treatment, maybe they're in day treatment. Okay, it becomes working on. If they're going to have a psych eval at some point, plans to start soon. And then the other thing too, for frequencies, think about what makes sense too. So for therapy, for example, Medicaid is not going to pay for more than one therapy session a week unless it's completely justified. Like a client experienced a really traumatic event and they're really struggling and they need therapy twice a week. So generally the frequency for therapy is going to end up being 1 to 4 times a month per month for 6 months. So again, in a perfect world, a client would be seen, once a week, every week. For TBS services, frequency, I usually set it as 2 to 8 times per month for 6 months, because much like case management services, if you are seeing your client on average twice a week, you will see your clients, in a good month, twice a week for 4 weeks, that's 8 times. We all know that sometimes our clients fall off the face of the earth for a couple of weeks, and maybe you only get to see them twice that month. Well, between 2 and 8 times, you could see them 3 times, 4 times, 5 times, 6, 7, blah, blah, blah. So the only time that you would have to write a non-billable note for attendance kind of issues would be if you saw the client less than 2 times. Because remember too, you should be writing non-billable notes if your client is not showing up to sessions or they cancel or something like that. Again, that's something that an auditor is going to look for. If you're saying, for example, like a client will participate in therapy 3 times per week for 6 months, but there's only 1 therapy session documented 1 week, an auditor is going to be looking for documentation of why those 2 other sessions didn't occur. Most people forget to write non-billable notes. So, if you're setting your frequency as 2 to 8 times a month, you might only have to write 1 non-billable note for the whole month for that client, as opposed to several per week. So that's why I'm suggesting that 2 to 8 times per month. For day treatment, your frequency would end up being 5 times a week. Most day treatment programs have the kids going every day, 5 times a week for 6 months. And again, I did mention earlier that I do have a custom button cheat sheet for you guys. Like I said, it has all of the frequencies and the progress and the status for you. So don't worry about, making sure that you are scribbling and scrambling to write down all of the different frequencies for this. I will make sure that you guys get that in an email. One that is different is the psych eval. So the frequency for this is actually going to be once a year for a year, because again, Medicaid only pays for one psych eval per year. So that's why it's set as once a year. And then let me go back up. The external physical and behavioral health appointments. This is what I kind of call the service coordination goal. So this particular goal is what, again, allows you to coordinate with other agencies, take them to food banks, you know, things like that. So my suggestion is to always set that frequency as needed. You know, your client might as needed per month for 6 months. Your client might need some linkages 15 times in 1 month and 0 in the next. So you don't want to kind of pigeonhole yourself into saying, oh, I'm only going to give them 3 referrals a month or whatever. Because again, if you're saying, oh, I'm going to give them referrals 3 times a month and you don't do any, Medicaid's going to come in and say, why did you not refer them to anything? Do you guys have any questions about the short-term goals and frequencies and things like that at this time? Okay, let me go on to the interventions then. So I'm actually going to start with the, excuse me, custom short-term goals and interventions that we were talking about. I actually always do those first so I don't get confused. So as you can kind of see right now, I have a short-term goal that was predefined by ICANotes, selected right now. It's kind of like that yellow one. And then over here are some interventions that are associated with this particular short-term goal. And again, they kind of change as you click on them. When you click on one of the short-term goals that was a custom button, you see that there are no interventions. And there are no interventions because obviously ICANotes, that was a custom goal. So you have to have a custom intervention to go with your custom goal. So what you will see over here on the right are, again, the custom buttons for the interventions. So this one right here, the very first one, I kind of know is the short-term goal for the service coordination. So over here, you would add the intervention for service coordination. So again, you're going to click on it. It's going to ask you, do you want to add this? Say yes. And you get the intervention of the QMHS is going to basically help the client access community resources. When you click on the next one, which is therapy, you'll notice that it doesn't actually select, but I promise you, if you click on it, it's going to select the correct short-term goal. So, okay, we've got therapy. Over here, your intervention is therapy referral. Yes, we want to add this. And basically, the only thing that you as the case manager are going to do in terms of therapy is make a referral to therapy. The therapists themselves, if they do have one that's coming aboard, is going to select the goals that they want to work on with the client. So if you are a case manager and you are updating a treatment plan, you're going to want to coordinate with that therapist to choose appropriate goals for that client. I'm honestly not sure as to whether or not at the agency, whether or not the therapist does the updating of a treatment plan or it's the case manager if there are both. I have seen it both ways. My personal preference is that the case manager generally updates the treatment plan in conjunction with the therapist, because the case manager is generally seeing the client more than the therapist, you know, maybe a couple of times a week for a few hours versus once a week for an hour or so. But again, it varies from agency to agency. So basically you're just referring the client to therapy services. And then once the therapist comes along, you know, they add their interventions under the short-term goal of therapy. So you can kind of see how it's nice and broken up by everything. Okay, so for TBS services, again, we click on it. There are 2 interventions for TBS. Most of the other ones only have 1. You have the referral to TBS services, and then you have the actual services of TBS itself. So again, one of the interventions is just a referral, and then the next one is actually utilizing evidence-based practices to assist, blah, 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 blah. And then there's a couple more here. I'm going to do day treatment last because that one's a little confusing. This one is the psych eval. So you go, again, just making a referral to, for a psych eval rather. And then day treatment. Okay. So day treatment can have 1 intervention to start with, or it can have a few. So if you know that your client is already going to be in day treatment, you're going to want to add all of the interventions. If you are just making a referral, you're just going to want to add the referral. So I'm going to show you kind of all of them so that you guys can see what I mean. So I am going to click on the day treatment referral. And that's basically saying that the case manager is making a referral to day treatment. And then there are 3 more interventions that go with day treatment. So the first one would be that the day treatment worker basically provides services. The day treatment worker collaborates with the team members for a weekly schedule. And then the day treatment worker is basically assigning the client some homework every week. So there it is. So right here, the QMHS will refer John to day treatment. The clinician here would be you as the case manager. So let's see, I'll make Kia the case manager. And then let's say these other interventions actually become the day treatment worker. So let's say, you know, Shonda is the day treatment worker for this one. So you'll just kind of notice that the interventions are being performed by different people. 9 out of 10 times it's going to be the case manager. But, you know, again, if we go back up here to TBS worker, you know, let's say that the clinician is, we see, you know, Robert could be the TBS worker. So just keeping in mind that, you know, you're going to want to give the appropriate staff member the appropriate intervention as well. Yeah, did you have a question, Robert? Did I see a hand?
Question.
Yes.
I guess, you know, when you are, you know, letting us know the different recommendations that the caseworker should make in terms of the treatment plan, it's a little confusing because I'm trying to just figure out the best way that we should go about, you know, doing the treatment plans. Because when we get a client, me as the therapist, I've been doing the eval and then doing the treatment plan. So what you're saying is basically that the caseworker should be making the treatment plan and then making those referrals to me?
So if you are going to be doing the evaluation, you're writing the initial treatment plan.
Right.
So you, based on what you see in the assessment, you are starting with the interventions because it's, again, based on what you see. So when the caseworker gets the case, if it, you know, isn't staying with you, they're going to work off of the treatment plan that you've created. And they are, going to basically figure out whether or not there needs to be short-term goals added after they've started working with the client. They're going to need to see if maybe a service needs to be activated. Maybe you're saying, okay, I don't necessarily see a need for day treatment at intake, but 2 months later, the case manager is like, oh, this client could probably go to day treatment kind of a thing. Then they can do an update and kind of activate that.
Okay.
So,
Gotcha.
yeah, so you're basically making the initial treatment plan off of what you see. And the case manager is going to basically come in afterwards and do any updates that need to happen. Most of the time, I see that the initial treatment plans are sufficient for the first 6 months, because you don't necessarily know how the client's going to respond to those interventions. So I don't generally see updates until that first 6 months. Does that make sense?
Yeah, for sure.
Okay, cool, good. Yeah, no, you are on the right track. So, okay, let me go back up here to some of the kind of predefined interventions from the short-term goals. So back up here, my short-term goal was for the client to attend psychoeducation for anxiety. And then you can look over here to the intervention column, and lo and behold, an intervention is to provide psychoeducation. So I'll click on that one, and it becomes an intervention in the treatment plan. What I have discovered over the years is that the more relevant the intervention, the higher up on the list it's going to be. So providing psychoeducation is probably the most relevant intervention that I'm going to get for the short-term goal of attend psychoeducation. You can certainly add some more interventions. Uh-oh, there we go. I don't know what just happened. That was weird. My screen is all blurry. But, it, again, depends on what you want to add for the client. Hold on a second. I don't know what happened to my screen. All of a sudden, it just kind of went all blurry on me. But, okay, I can still see. And then again, the next one, learn a mode of vocabulary. Oh, look, teach a mode of vocabulary. I can click on that one. And sometimes you may have to fill in the interventions too. So like I see this one, blah, 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 learn and practice a mode of vocabulary in order to express feelings in appropriate ways, at least. I generally take out the at least, and just leave it as, in appropriate ways or whatever. And then, as I was saying earlier, again, the interventions are defaulting to therapist/counselor. You just want to select it and change it to QMHS. QMHS. And then every now and then too, you'll get something like therapist/counselor will provide therapy. You can change therapy to say QMHS will provide interventions or strategies or suggestions or something like that. You just don't ever want it to say QMHS will provide therapy, because a case manager is not going to be providing therapy. If that makes sense. So after you've chosen a short-term goal, you can again choose multiple interventions. Several of them do have multiple ones that can be added. And again, I'm sorry, my screen is so blurry. I literally have no idea what happened, but I don't want to shut it down and restart, because there's not too much time left, and I want to make sure everything is, covered. So once you have chosen all of the interventions that you want for your client, you want to, again, kind of fill in those frequencies, time periods, and durations. So in general, I suggest that your frequency for the majority of the case management interventions be that 2 to 8 times a month for 6 months, because like I was saying earlier, in a perfect world, you'd see your client twice a week, every week, if needed. So you have that 8 times a month. There are going to be, again, some that you're only doing once. So for a lot of those referrals, you're only referring them once. So this one says refer client to individual therapy. Frequency would be, once. I do per year, and I couldn't figure out how to just do it kind of like you're referring at once. So I'm doing once a year for a year, basically. And then your name as a clinician. If you are going to be doing the accessing variety of community resources, your frequency again will most likely be as needed, because you are doing that as many times as you need per month. The day treatment worker ones, again, that could be 5 times a week. It could be 3 times a week, just kind of depending on the curriculum. And you probably have a better idea of that if the client is actually enrolled in that, and you can kind of communicate with the day treatment worker. Are there any questions on the interventions kind of section? It's kind of, this is kind of like the fun part, so to speak, where you can choose interventions that, you would like to work on with the client and that are suitable to the client's strengths. You want to be able to choose some interventions that the client is going to enjoy as well. The next tab is the strengths tab, and this is basically just choosing some of the client's strengths. So behavioral, cognitive, communicative, family, motivation, other, physical, relationship, social, spiritual. So when you click on each of these, you're going to kind of get a list of some of the strengths for that client. So behavioral, maybe generally compliant. Cognitive, they're verbal, they can make their needs known. Communication, they have good communication skills. For family, maybe they have the ability to use their family support. For motivation, they're motivated for treatment. With physical, I don't know, they are physically healthy. Social, they have they interact well with others. So whatever the strengths are for your client, you want to note them here. You can obviously type in strengths, you can edit, you can, do whatever. Make sure that, every client has at least one strength, even if they don't think that they do. So, at least one strength needs to be here on this particular tab. With that comes barriers. The way to do this one's a little bit different. You can kind of choose, there's cultural, religious, cognitive, language, motivational, and emotional. And then there are the staff plan to basically break that barrier. So if I choose like cognitive, there could be a cognitive barrier. My plan would be instructions will be basically given to the client's level of understanding. Okay, well, we can set that. Let's say that there's a language barrier. You can get an interpreter as needed, set that one. For emotional, maybe they need an increase in their social support system and finding community support. You can set that. And again, you can totally write in other barriers. Just make sure that you also have a plan to address it. So let's say that transportation is a barrier for your client. Your plan to get around that would be, you know, sessions will be held via telehealth, or sessions will be held in the client's home. So you're saying how you're going to get over that barrier to assist the client with their needs. These are the strengths tab and the barriers tab are generally not touched too much during an update. Sometimes there are barriers that are added or removed, but for the most part, I find that these two tabs are pretty untouched. For status, this is kind of what I was talking about, where you would need to add a little personalized sentence in an update. So it basically says sections 2 and 3 are for follow-up plans only. So sections 2 and 3 you only need to do during updates. But an initial plan is always going to need the following 3 buttons. Face-to-face. So it's basically saying, okay, we met with the client face-to-face, but it may not literally mean face-to-face. It could be over the phone or telehealth. It basically just means like, hey, I reviewed it with the client. Like we had a conversation about this treatment plan. Clinical review, again, the supervisor agrees with the assessment and the goals and interventions in this treatment plan. And then everything is medically necessary. All the services, all the interventions, they're all medically necessary for the client's mental health improvement. So if you're doing an initial plan, those are the first 3 buttons under number 1 are all that you need. If you're doing a treatment plan update, you're going to want to do sections 2 and 3. So basically section 2 talks about the progress that the client has made in meeting their goals. So it will be non-apparent, minimal, some, I can't read that one, moderate, fair, good, I think it says excellent or finished, difficult to assess. So you're going to basically want to choose the level of progress they've made. So like, let's say that this client has made some progress. So some progress has been made in reaching the goals. And I am gonna maybe choose on number 3, the recommendations, continue current plan, more time is needed. So that's pretty much all you really need to say in terms of progress. But again, you just want to add a little sentence of why you're choosing this, basically the justification. So you could say something like, client has identified several coping skills that can be used. Sorry, again, I don't know what happened on my screen, so I can't see really well. Sorry if I can't spell. That can be used to reduce anxiety, but still needs to learn to use them consistently. So that's basically giving the justification for why you're continuing the plan on. And I never do like status and discharge plans, so you can completely ignore number 4. Don't even worry about number 4. So just remember, again, for initial treatment plans, you only need number 1. For reviews, you need 1, 2, and 3. And each problem is going to need to have the status update. So if you have more than 1 problem in your list of active problems, you have to do this tab for each one. It's not going to copy over to the next one. And then last but not least is compile plan. So what you'll do here, again, you select the meeting date of when you met with the client face-to-face. So you know, when I was doing case management, there would be times where I knew I was going to be seeing the client the next day. So I kind of wrote the treatment plan ahead of time and brought a copy to the client. And if there were changes, you know, I made them there and fixed them up in the computer, and we signed. So you just want to make sure that your meeting date is the day that you're talking to the client about the treatment plan. And then you want to, again, choose what kind of meeting it is. Initial, there's a 6 months, a 90-day, and then there's an other. When you choose other, you actually get a little box, and you can write something like interim treatment plan update if it's like before that 6 months. And then just hit OK. And then you're going to want to add the treatment team members. So you are obviously part of the treatment team. So, and then you want to choose your role. So maybe you're QMHS. If you double click in that box, you'll be able to type into it. Let's say that, where are you? Let's say maybe Kia is a TBS worker. And then you're going to want to type in, again, if you double click, I spelled that wrong. John Test client. And then obviously you'll want to add like their parent or guardian if they're a minor. Mrs. Test, and I actually want to say mother is one of the, and then over here it says completed. Completed just means who actually wrote the plan. So let's say that, you know, Shonda wrote the plan. You're going to just check the box that says completed. You know, you might see that if the assessor does the initial plan, you might see that their name is checked. But if you update the plan, you want to make sure that your name is then checked. And then you'll also see underneath, like as you add names, they show up as present at today's meeting. You just want to check off who was present, because not every treatment team member might have been there. You know, let's say, you know, Kia as the TBS worker was invited to the treatment plan review, but she was unable to attend because she had another client. And it was just Shonda, the client, and mom. This box right here basically is asking whether or not you want to include the diagnosis in the treatment plan. Just hit yes. And then underneath it's asking, do you want to include the medications in the treatment plan? I generally say no. Again, that could be a whole huge list of medications. It's just taking up unneeded space. So before I go and kind of do this preview part, I'm going to just quickly skip back to the very first tab, which is list of active problems. So again, all of that work that we just did was only for anxiety. So if your client has more than one diagnosis or more than one problem, you need to repeat the process for the next problem. So again, I'm just kind of picking a few things here to basically get another list of active problems. So after you update or create that very first problem or need, and you go again through all of the different tabs and you end up back at compile plan, you'll basically see two big gray buttons. One will say preview plan for just this problem, so whatever problem you just added, or preview the comprehensive treatment plan, which is all of the problems and the strengths and the barriers. So when you are getting ready to actually complete a treatment plan and have it be ready for a client to sign, you're going to want to choose the comprehensive treatment plan, because that's going to pull everything that you just did, not just one problem. And then I'm also going to call your attention up here to last done and next due. It is super important that you make sure that these 2 dates are correct, because this is what is going to trigger the system to tell you whether or not a treatment plan is up for review. If you don't manually change these dates, your treatment plan is going to come due at 3 months, but all of the dates are saying, hey, it's due at 6. So you might be going, I don't understand why it's telling me my treatment plan is due. It's really not. So again, last done is today. And you'll see that when you put in last done, it's automatically populating the next due for roughly 3 months out. You want to make sure that you change the next due to 6 months out. So instead of April, it is July 16th. And then over here too, you'll, you don't necessarily have to fill this in. It's basically a start and a stop time. The treatment plan itself doesn't bill. So when you are reviewing the treatment plan with a client, you're also going to need to do a treatment plan review note. Yes, Shonda.
So I'm just going back in the notes I've been taking, and there was something that you mentioned, and I thought it was last done, the day you are completing, to go 1 year out.
So wait, from right here, you mean the last done and next
This
due?
was probably 15 slides ago, but
Okay.
It was more so when you were reviewing, you know, actually towards the beginning.
Was it with the long-term goal?
These were when we were beginning the tabs, and you were, the type is always to be general. Last done is the day you are completing.
Okay.
Next done is the update day. And I saw that it went 1 year out. And I'm just making for certain that this is the same thing, of course, when you say last done and next due.
So similar. So I know what you're talking about now. So, okay. If we actually go back to the treatment plan list, which is kind of the first thing that I talked about, you'll see the name, the treatment plan name, type, last done, next due. So the last done, again, I'm sorry, my screen's blurry. It literally went blank and then blurred, and I was like, oh, I'm not touching this. So last done is going to be, again, the day that you are reviewing the plan, and then next due is 6 months out. So that's when you're going to review the treatment plan the next time. However, let me go into the plan real quick. When you're looking at the long-term goal, your target date and your completion date, I think this is maybe where you're having the question. So your target date is going to, again, be 6 months out. So basically, in a perfect world, your client would have achieved their long-term goal in 6 months, and boom, you can close the case. Clearly, this doesn't really happen. So basically, your target date is always going to be 6 months from when you start. So it's that first treatment plan review. So again, by that first treatment plan review, we would love if the client was done and we could close their case. Generally isn't going to happen. So we're setting our completion date for these goals to be a year out. So we're really giving the client a year to complete these goals. 9 out of 10 times, it doesn't happen. And you're going to be continuing it on, which is why the long-term goal is so broad and it's set for a year out. And again, that's why the short-term goals are the same thing. You know, we want that target date to be 6 months, but we're really saying, hey, we really want this completed from a year from now. And then let me go back to compile plan. Last done and next due is, you know, just think about it that these dates kind of correlate with what is on the treatment plan list, the list tab, where we saw last done was today's date, next due is 6 months out. Again, some agencies do their next due for a year, but you know, generally most people are doing theirs doing a review every 6 months, because 3 months is generally a little too soon to tell. And, you know, about the 6 month mark, you're going to have a good idea whether or not something needs to be updated. So your last done and next due here are basically last done, day you did them, next due 6 months. Does that make sense? Okay. And again, if you don't change the next due to 6 months, it's going to default to 3. Unfortunately, there is no way to change that in the system. I've actually called and asked, you know, is there some button I can push to make it be 6 months out? And they're like, yeah, no, sorry. So just make sure again that you change the next due. So after all of your treatment goals, interventions, strengths, barriers are set, you are going to hit preview comprehensive treatment plan. So when you click that button, it comes up with everything. Oops, I did forget to choose who was there though. So let me try that again. Preview. Okay. So here you basically see you're previewing it. So here is everything that has been done on these past tabs. You can make like really little changes here. Like if you notice a spelling error, but it's not going to change anything on these tabs. So, you know, if you have to change several things, I would just go back to the associated tab and do it. The other thing is if you go back and, you know, make some changes and things like that, you have to hit the preview again, or it's not going to pull any of the changes. And there is the button down here that says compile note, save to progress notes. This is what actually generates a copy of the treatment plan. So make sure that all of your changes and updates have been made before you click this button, because if you click this and then you're like, oh, I made a mistake, and you go back and fix it and do it again, you're just going to keep getting copies of the treatment plan with like little minuscule changes. So once your progress note, or I'm sorry, your treatment plan is, you know, you're like, okay, it's great, we're good, compile note, save to progress notes. And it's going to give you, it's asking you like, okay, well, the treatment, you've entered a date when it's due. Do you want to set up a reminder? I generally hit no. Your reminder is going to go to your ICANotes inbox, and I never ever read that, like checked that when I was using ICANotes. So here is where your treatment plan lives. This is what a compiled treatment plan looks like. Again, you can make little minor changes here. Like if you're like, oh, wait, it's supposed to be John Test Jr., you know, you can type a junior in there or something like that. But again, it's not going to change it in the actual treatment plan itself. It's just on this. And then you would basically sign and lock the note as the case manager, and then you're most likely going to be sending it to your supervisor for review as well. So if you click this green button here, it's basically saying, you know, who do you want this to be sent to for co-signing? Let's, you know, you're sending it to, you know, your supervisor. So when you sign and lock it, it's going to get forwarded to your supervisor. So let me do that. I'm just going to sign it. We're good. And once you sign, this isn't so much for this, but in progress notes and things like that, when you sign and lock it, that's when it gets sent off for billing. Again, treatment plans don't bill, which is why you need to do the treatment plan note. Review session note with it. So in order to get a client signature on a treatment plan, there's no need to, you know, create a copy of it or anything like that. So like, let's say, okay, the treatment plan is done. Once we go back to the chart face too, you'll see that the treatment plan shows up here in the notes section. And you'll also see on the chart face that these are the list of active problems for the client. So you kind of get a quick glance at, okay, this is what the client is working on. If the client had more than one treatment plan, the different treatment plans you could select from the different treatment plans and see what the active problems were. This is one of the reasons why you want to make sure that the default treatment plan is chosen. So let's say now you're with a client, you've reviewed your treatment plan, and you're ready for a signature. So all you need to do is go to compiled note. It's going to bring up your treatment plan that you've done, and you're going to go here to these boxes that say capture signature, and then you're basically going to choose who the signer is, basically. So I think that says patient. We're going to go with patient. So it'll choose her name, John Test, hit capture signature, and your little signature box is going to pop up. So you can have them sign with their finger, with a mouse, whatever. I'm pretty sure, yep, I still have a touch screen. So once you have the client sign, once they're satisfied with their signature, accept signature, and it's signed. So there's no need to like recreate copies or anything like that. So you can have the client sign, the parent sign, whatever. Let me go back here real quick to the chart face. And then when you are updating a treatment plan, it is honestly pretty much the same thing. You know, you're doing the same steps throughout everything. You know, you're going into the treatment plan the same way. You are going through basically, and you're just going and changing dates. This is where you might also be changing the progress and the status. So let's say a client didn't really want to practice their emotive vocabulary. You could say the client decided not to complete and it was ineffective. So let's say the relevant psychoeducation, maybe they completed it. So, and this too is also where if you had a client who completed a goal or discontinued a goal, you're not going to want to change the dates of those if you are continuing everything else. So the client completed the goal, you want to leave the completion date as the day that the client completed it, or the day of the review. So like, let's say the client completed this goal and it was effective. The target date was 7/16, blah, blah, blah. So maybe the completion date is actually, I don't know, January 27th or something. Oops, wrong year. 2020 went too far. Let's go with like February 17th or whatever. You know, you don't need to continue that goal because it's done. Same thing here. The client decided not to complete. You know, the completion date or the discontinue date is basically when you decided to stop that goal. I would say 9 times out of 10, it's going to be the day that you're doing the treatment plan, unless you are going in and doing multiple updates before that. So for a short-term goal that has been completed or discontinued, the target date and the completion date might be pretty similar, if that makes sense. Maybe off by a few days if you're reviewing a couple days before or a couple days after the treatment plan is due. And then, you know, you again go back, you can add new goals if you want to. You can literally just push everything out 6 months if you're going to continue to work on that goal. And then same thing with a long-term goal. Like, you know, all you would need to do if you're continuing a long-term goal would just say something like, goal is being continued at this time. And then at this time, and then you set your new dates. for the 6 months from that review and then a year from that review. So we know, okay, the client hasn't met their goal yet. They're continuing it. There have been no changes to the long-term goal. My suggestion would be if you have a client that has been working on the same long-term goal for more than a year or a year and a half, switch up the long-term goal and some of the short-term goals. There could be something, maybe they need some new short-term goals or a new long-term goal to work for to make some progress. So, that is pretty much it in terms of updating and creating and things like that. The one thing too, I will caution you guys about, make sure that these boxes are not checked if you have those as active problems. One would think that checking these boxes would make the problems active. It actually makes them inactive. And when they're inactive, they're not going to show up when you compile the treatment plan. So it's actually kind of nice because if you had a goal that was like housing or education and the client achieved that goal, you would just make it inactive basically so that it doesn't show up on the treatment plan itself, but it's still there. So if it becomes an issue in the future, all you need to do is basically uncheck the box and it's back in circulation, so to speak. So does anybody have any questions, anything that they are still dying to know or are confused about or anything like that?
I just think it's going to take practice. This is a lot of information.
It is. It absolutely is. My biggest, my best advice to people rather is when you are starting to do treatment plans, don't rush through it, because the faster you go, the more likely you are to make a mistake, and you're just going to end up spending more time on it and than you would have if you just took your time to go through it. And I would say, have the instructions with you the first couple of times that you do it. What I can do as well is assign you guys to John tests so that you can go in and practice on
That's
this
what I was
chart. Yep.
you.
So that way you're not messing up a live chart.
That would be awesome, because this is actually very good in that there's all the drop down boxes and everything is seemingly right there. But again, I've been doing clinical social work over 20 years and we hand wrote everything. I'm used to writing. I'm used to manually putting in everything and not dropping out tabs. So I'm following along with these tabs and I'm like, what is that? Why would you do that? Well, it doesn't make sense that you would do this.
Right.
So thank you for the practice.
Absolutely. And I will say though, you can't work on the same chart at the same time. Like you can't be in the same chart at the same time. So I'll just kind of caution that. But again, you can go in and make as many practice treatment plans as you want. It's not going to mess anything up. There's no insurance information for this client. So you can even practice progress, like whatever you want, basically. It's not going to mess. Do what?
And how do you do that?
What?
For
the
practice assessment or a practice treatment plan or.
So you're both now assigned to John Test. If you want to do a practice treatment plan, you would just kind of navigate to their chart. And for the treatment plan, you just go in and you add the treatment plan, like with the steps that from before, or the different notes are kind of down here. So if you are doing a treatment plan review, you're also, again, because the treatment plan itself doesn't bill, you are going to want to do a case/social worker note to go with it. and you basically are saying like, I don't know, client, met with client and family to review, I can't spell, I can't see, review treatment plan. I would say talk about some of the changes that were made. So you can say, talk about progress, talk about any changes made, talk about any changes that you make. Basically client's response, just your regular old progress note. You're just kind of focusing more on, updating the treatment plan. So again, you would bill this just as a normal case management note. It's not billed as anything special. If you are a therapist as opposed to case manager and you are doing a treatment plan update, that is still going to be a case management note and not a therapy note, because the review itself is a case management service. So, your everything in terms of your billing codes are just the same, again, as your regular case management note. And again, if you wanted to, back on the treatment plan, you can do like the time frame, like on the compile plan tab, it had a spot for time. You can assign it to, this particular note period, but I never really fill the time in, because you can see that, okay, it was clearly done on the same date. So this is the treatment plan that goes with this note. So, but yeah, I definitely recommend practicing, because I found that people who don't practice are the ones that are messing up, and then they end up getting frustrated, and they're leaving their treatment plans to the very last minute, and then they're expiring, or whatever. So take your time, go through it, don't rush through it. It took me, when I first started doing treatment plans and ICANotes, it probably took me a good hour to write an initial one. I can write an initial treatment plan in like 20 minutes now, because I've done it so many times. I could probably do it from beyond the grave at this point, because I've done it so many times. But practice does make perfect. And as you get used to the system and like what it's asking and things like that, what you need to put where, you'll kind of be able to speed it up, so to speak. And you might be able to do either an initial or a update in 20-25 minutes. So my other suggestion would be, until you know how to update and navigate through the treatment plan, don't do it with a client, because you're going to get frustrated, and they're going to get frustrated because you're taking so long and things like that. But when you do know how to go in and update, it is actually nice to sit with a client and go and do it, because you can discuss with them, okay, well, this is this intervention, what do you think about that? And you can stretch that literally into an entire session. So that could be a good hour or hour and a half of billing if you're really going and discussing each intervention and things like that. So it's almost like a freebie of a session where you don't have to plan anything or anything like that. So okay, anything else that you guys have in terms of questions? Yes, Kia.
I was going to say, I just wanted to say that this has been helpful to me. One of the things I was a little on edge about was that I knew that some of my treatment plans were coming up on 6 months, and I didn't know exactly what I would need to do or how I would do that piece, because when I was with I for Change, I never really got that far in. So this has been really helpful to me, especially knowing that, because I've seen a lot of my treatment plans are kind of like, if I can say it like this, they're kind of like basic. And as I've worked with the clients over this last 6 months, I wouldn't say there's a lot of things, but there are some things that I think may need to be included in their treatment that I've been doing with them. For instance, some of that social stuff of helping them get and things of that nature, helping them to become independent or get housing, that or work to that progress, to that point. So this has been very helpful to me and what I will need to do in the next month when
good.
that 6-month mark comes up.
Oh, good. And you know what? I actually wrote a lot of your clients' treatment plans. I'm not gonna lie. And I when I do them, I do tend to make them pretty basic because, you know, I don't know the client. So the point is I'm like, okay, well, let me give them the basics. And then, yeah, by the time that 6-month mark hits, you know, the case manager is going to know, okay, I need to change this. I need to change that. So I would say most people who are writing the initial treatment plan do try to make them a little bit more basic, unless they do know the client, you know, for that reason that you just mentioned. Okay, I'm going to get to know them. So what I'm going to do is I am going to upload the recording itself has to like process or whatever on my computer, but then I will make sure that it again gets uploaded to YouTube so that you guys have the recording available. I will send Derek the link so that he can email it out to you guys. And I will also include an example of a complete compliant treatment plan, so you guys can kind of see, okay, this is what it's supposed to look like when it, you know, kind of comes out compiled, and this is what it would look like if it was printed. And then I will make sure too that you guys get that kind of custom button cheat sheet that I was talking about, because it will tell you the frequencies of each of those custom buttons, like the therapy and the TBS services and things like that. So you don't have to try to guess about that. And then ICANotes also has a YouTube channel with some videos and tutorials that are actually pretty good. So I'll make sure that that link gets included in the email as well, because they will take you through updating treatment plans or creating them and, you know, things like that. So I will definitely, today's Saturday, I'll definitely make sure that that's done by the end. Everything is out by tomorrow evening, by Sunday evening, so that, you know, there's time for you guys to practice and stuff before treatment plans come due. So awesome. All right. Any last questions or concerns or anything like that?
No, thank you.
You are welcome. All right. Well, enjoy the rest of your day. Stay warm. I'm not sure if it's cold out. I haven't been out yet. Oh, of course it is. It's January in Cleveland.
No.
Awesome. Oh, great. All right. Well, have a good weekend, guys. I will talk to you later.
All
right. Bye.
Bye.